Thank you very much, sir. It was very, very informative for all of us, I suppose. Next, it is my great privilege to introduce our esteemed speaker, Dr. Bhavneet Bhalla. He is an Associate Professor, NILM University, Academic Director, World Laparoscopic Hospital, Associate Editor, World Journal of Laparoscopic Surgery, and Chief Coordinator, TUGSS Endoscopy. Sir is going to talk about surgeon endoscopist. The future is hybrid. Over to you, sir.
Thank you, Dr. Neha. So with the permission of the chair, I would like to start my talk. So I'm going to talk about a topic which is really close to my heart, and I believe it is relevant to all the surgeons present in the hall. I'm going to start my presentation by asking a question to all the surgeons here, that are we as surgeons ready for the future? I'm talking about a future where the lines between surgery and endoscopy are no longer rigid, but are seamlessly integrated. A future where a surgeon is not just a surgeon, or an endoscopist is not only an endoscopist. Instead, we evolve into something greater or better, which is a hybrid physician. And the question is not whether this change will happen, but how quickly we will be able to adapt to this change. The future which we keep on talking about is not just coming, in fact it is already here. So I'm going to give 8 reasons which I believe every surgeon should think about why surgeons now also must be endoscopists. The first reason is endoscopy is actually a part of our own surgical heritage. Both laparoscopy and endoscopy have evolved from common roots, and throughout history you will find that surgeons have played a vital role in the diagnosis, in the design and the development of endoscopic techniques, procedures, and the development of the equipments. So evolution of flexible endoscopic procedures is greatly indebted to surgeons. Whether it is a technique of colonoscopy or refining the technique of polypectomies, ERCPs, simple procedures like variceal banding or PEG, surgeons have always been at the forefront developing and refining these techniques. And not just in the past, surgeons continue to lead the advancement of flexible endoscopy as an interventional platform. Just to name a few stalwarts of the galaxy of endoscopy now, whether it is Professor Amit Mahdev, Professor Inoy, Dr. G.V. Rao, Dr. Amol Bape, these are all world authorities in their own sense in the field of GI endoscopy, and I'm happy to tell that they are all surgeons by training. My second reason is, although having originated as a diagnostic modality, endoscopy is now rapidly evolved into a therapeutic and interventional modality. Flexible endoscopy is being used increasingly to perform therapeutic procedures that have replaced conventional surgical procedures. So this is a very interesting graph here, and if you look at it, this represents the loss of general surgical case volumes to GI endoscopy. So somewhere around late 1990s or early 2000 year, the work volume of general surgery and laparoscopy combined is showing a downward trend. That doesn't mean that we are not doing less surgeries than we were doing earlier. In fact, the truth is that the graph, if you look at the green line there, which represents the GI endoscopic work volume, is basically going up. So more and more surgical diseases, surgical patients are now being managed endoscopically. Just to name a few, whether it is esophageal procedures like a foreign body removal or a stricture dilatation, gastric procedures, pyloric obstruction, enteral feeding access, drainage of Vaughan, management of a pseudopancreatic cyst, obviously the stone and stricture diseases of the CBD, or conditions like a stricture of the small bowel or colonic strictures, all these are now being managed endoscopically. So a slow but steady transition is happening from the scalpel to the scope. And therapeutic endoscopy is gradually becoming another way of treating a disease which earlier was treated by surgical intervention. My third reason is endoscopy is now actually an integral part of surgical practice. And surgeons use endoscopy not only as a treatment option, but also for pre-operative, intra and post-operative evaluation of their patients. Preoperatively, it is very helpful for diagnosing and grading of certain diseases, for localizing the lesions when you are operating in the esophagus, gastric lesions, or in the colon, and for planning the best operative approach. Plus, it also helps you build up the patient by providing nutritional support to make your patient fit to undergo that surgery. Intraoperatively, endoscopy is helpful again to localize the lesions, but also to evaluate the anatomic or the anastomotic results of your surgery. So whether you are doing a sleeve or a Heller's or a Nissen's, or you have a long staple line or an anastomosis during a foregut or colorectal surgery, intraoperative endoscopy provides a real-time feedback during these procedures and thus serves to guide the operating surgeon. Now, in today's era, an interventional endoscopist can nowadays do local excision of tumors similar to surgical excisions with techniques such as ESD and EFDRs. On the same, on a parallel course, in the same hand, the GI surgeons can now offer precise and very, very minimally invasive segmental resections that give far better functional outcomes rather than doing a more aggressive reaction. In this competitive race, each of these two approaches have their both plus points and their weaknesses also. So a new laparoscopic and endoscopic cooperative approach, or what we today call as a hybrid surgery, has emerged out of this competition. And this integrates the stronger points of both intraluminal and intraperitoneal procedures, at the same time negating the weaker points and limitations of both these techniques. So hybrid surgery basically is all about cooperation and not competition. Now it could be a scenario where the primary surgeon is a laparoscopist and the endoscopist is just assisting the surgery, or it could primarily be an endoscopic resection with a laparoscope just watching over the endoscopist and helping him to do a safe job, or it could be a combined approach. So as I said, it's basically all about cooperation, and it enables the precise location and resection of the lesions while respecting the oncological and surgical principles. Post-operatively, again, endoscopy has a very important role in the surveillance of these post-surgical patients. Whether you have a case of a pre-malignant disease, you are trying to watch out for the Barrett's, evaluation of colonic polyps, or malignant diseases post-operatively after a resection of the esophageal, gastric, or a colonic carcinoma. More importantly, post-operative endoscopy is now becoming a cornerstone in the management of anastomotic leaks, fistulas, bleeds, marginal ulcers, or even retained CVD stones after a surgery. My fourth reason is, with the advent of robotic flexible endoscopies, EUS-based procedures, and devices which enable you to do endoscopic suturing, the fields of endoscopy and laparoscopy have actually merged. Now, robotic flexible endoscopes, by extending the degree of movements and providing triangulation through robotic arms, facilitates the performance of these complex resections. In fact, the world's first colorectal ESD using a flexible endoscopic robotic system was performed recently, a few years back in 2020. And with the advent of endoscopic ultrasound, the scenario has undergone a sea change. EUS not only is an established modality for diagnosing and staging of GI malignancies, but it also serves as a robust platform for therapeutic procedures. A good example of that would be doing a EUS-guided hepaticogastrostomy, or to name a few more, procedures like rendezvous ERCP, cystogastrostomy, a drainage of a walled-off necrosis, a simple gastrojejunostomy, or a choledochoduodenostomy are basically all surgical procedures in their true sense, but are now being done via the EUS modality. So this is just a representation of how a EUS-guided gastrojejunostomy or a choledochoduodenostomy is now being routinely done under the guidance of a EUS scope. And with the availability of these endoscopic suturing devices, now we have more interesting procedures and which also enable us to manage post-operative leaks and fistulas. My fifth reason is that the surgical societies all over the world are advising and rooting for training of surgical residents in GI endoscopy. SAGES, in fact, has developed this Fundamentals of Endoscopic Surgery program, which is available free of charge to all those who are interested in learning endoscopy. It has been incorporated in the general surgery residency curriculum, and all the fellows, all the residents must undergo this and pass this first certification before they can appear for the ABS qualifying exam. However, I must add a point here that there is actually a lack of surgical, trained endoscopic, structured endoscopic training programs for surgeons in general. And this is true not only for the third world countries or the developing world, it is a fact all over the world. Next point is, endoscopy actually comes more naturally to surgeons. In this wonderful study of a prospective analysis of more than 3,500 endoscopies performed by surgeons, it showed that the surgeons did the procedure with excellent outcomes and no complications were reported in almost 98% of the patients. Similarly, a prospective analysis of more than 13,000 colonoscopies, again done by surgeons, showed just a complication rate of 0.2% and a perforation rate of 0.007%, which is well within the recommended guidelines. My next reason would be that there is actually a dire need for more endoscopists. And this study by Kocher, which was published in the New England Journal of Medicine way back, they recommended that there is a poor ratio of trained endoscopists vis-a-vis the population who requires it. And they strongly suggested that the burden of screening colonoscopies itself, is already outstripping the need or the supply of the healthcare providers, and without the contribution of surgeons, the patient access to appropriate care would be severely limited, and hence surgeons must perform endoscopy. So this is the position paper which was issued by the Society of Gastrointestinal Endoscopy of India on endoscopic training in our country. And they have recommended that level 1 or primary level endoscopic skills, which basically include your UGA endoscopies, sigmoidoscopies, and simple therapeutic procedures, could be imparted to any skilled physician with interest in learning endoscopy. And the PG, the postgraduate physician or a surgeon, would be the best suited candidate for such trainings. Let me just wind up my talk by addressing this vital issue. Some surgeons still fear that there may be a medico-legal implication if they do endoscopy. Well, all I can say is that the defense against this lies in the data. Now, since the curriculum of the PG degree mentions endoscopy as a part of our training, naturally surgeons are entitled to practice it to the extent that they have been trained in this. So endoscopy is not actually a different specialty, it is just a different way of doing surgery. Endoscopy procedures do not belong to either surgeons or physicians, but they actually belong to the deserving patient and must be done by a trained specialist. So the take-home message from this small presentation is that the future of surgery will be influenced by the future of surgeons performing endoscopy, and we must continue to expand the utility of flexible endoscopy in surgery. It is an essential component of surgical practice, and endoscope is just one of the many tools of a surgeon, as essential as any other. Surgery has evolved, and the surgeons should also evolve. So way back when I started my surgical career, it was a common dictum to say that a surgeon without a scope or a laparoscope has no scope. I think in 2025, it is safer to say that a surgeon with 4 scopes has more scope. So ladies and gentlemen, the future is hybrid, and all of us should strive to become a surgeon endoscopist. I'll stop my talk here. Thank you. Thank you for the patient hearing.
Thank you, Bhavneet, for taking us through a very, very important topic, and I could not agree with you more. Today, I think it's important for all the surgeons to know that they are able to do their own endoscopies. It may not be possible today in a big corporate hospitals, but practicing in smaller places, in government medical colleges and other places, I think it's very important. And now I think all the associations are pushing it very aggressively. Our own association, Gastroendosurgeons, IAGS, has a course on it. a 3-day course where it's a certificate course, so for anybody is more than welcome to join that course and learn it. All over the world, Europe and America, surgeons do their own endoscopies, and more procedures in the future will be done with the help of endoscopy as well as laparoscopy or robotically.
Right.
So as you very rightly said, we are living in an era where we are moving towards hybrid procedures, and it is imperative for surgeon to learn all the technologies involved in that. Thank you very much.
Thank you, sir.
Just a quick comment, actually, Dr. Bhalla. This was very exciting, very good. I give you my own example. I was doing my fellowship. I was never trained endoscopically. And I would do a perspective of the US. The GI guys, you know, when one of my friends, when we graduated, I graduated, he graduated, he was doing GI fellowship and I was doing surgery. He signed a contract for $600,000 just by a gastroenterologist, 3 years residency. And the surgeons is like 300 to 400,000. So this is the technology really we have to embrace. Otherwise we'll be, you know, lag behind a lot. Yeah. And I'm a bariatric surgeon, and I always encounter my own patients have the complication like a sleeve leak. One of the patients basically had strictures, and I was trying to find the endoscopist who can put a stent there. So these are the things we have to, you know, embrace it and do it by yourself.
Very right.
So that's good message for all the incoming early career surgeons to embrace the technology. Thank you very much.
Thank you, sir.
Thank you so much, sir. It was very enlightening.